Good afternoon, everybody. We are still seeing lots of members come in. If you are a committee member, if you would please put your name in the chat so we can make sure that you are here. Michael, we are very short yet on a quorum, so I will let you know when we get a quorum, but probably just give it a few more minutes. It's just at the 2 o'clock hour. Let everyone still join. So thank you, everybody. If you are a committee member on the phone, if you would unmute, let us know that you are here. Thank you. We should get started in just a few moments.
Thank you, Sharon. I think, given that we're having a hard time getting our quorum together yet, let's maybe just skip on our meeting minutes. And it doesn't look like Dr. Brinton has joined us yet. So because we do have Aaron from California's Medicaid program on the phone, let's just go ahead and proceed with that presentation, and then we'll come back to the other items on the first item on our agenda. So we would like to welcome Aaron Toyama, a senior advisor from the California Department of Health Services, to explain to us an innovative social determinants of health addressing model that California has worked with the federal government in getting approved, and would like to have a presentation on that we think will last about 30 minutes, and we'll have some questions after that.
Hi, can everyone hear me?
Yes, thank you.
Okay, great. Well, thank you, Michael, and thank you, everyone. Happy to be here today, talking about what is essentially our largest current initiative in Medi-Cal, which is the title we give to California's Medicaid program. My name is Aaron Toyama. I am a senior advisor with the Department of Healthcare Services. That's the name of our state agency that administers Medi-Cal. And again, just happy to be here and want to thank you all for letting me join. I believe I shared a slide deck. I don't know if we're presenting that or if I should just kind of walk through the slide numbers.
Sharon, do you have that and can include that to present?
Yep, I sure do, Aaron. I wasn't sure if you wanted to present it yourself, so to walk through it, but I've got it right here.
Yeah, that'd be great. I'm just very unfamiliar with this virtual format, so if somebody could just go through the slides for me, and I'll cue you when to go to the next one, that would be great.
Yeah, sure, no problem. Thank you.
So Sharon, we're not seeing the slides. We're just seeing your logo for the Department of Health and Human Services.
Let me stop presenting and try again. It was showing on my screen. So let me try that one more time here.
Yeah, we've been experiencing this every once in a while, but I think it's due to network delays or something. Yeah, all we're seeing is just the logo.
Okay, yeah, it's showing on my screen, so I might be having technical difficulties here on my network.
All right.
I
Let
will
me see
try
if
to
I
get it
can.
up here.
Let me see if I can try and present it.
That's working, Michael.
All right.
Yeah, I could see it as well.
Okay.
All right, great. Thank you so much. So I'll just kind of go through this and then just ask to move to the next slide. We could start with the agenda. There you go. So I know we have about 30 minutes for this presentation. The presentation itself shouldn't take very long, and so hopefully we could have some solid question and answer following. I know there's interest in hearing about CalAIM and some specific aspects of it. I'll start off by saying, CalAIM is a huge multi-year initiative that we are now going through in the department. And it's really not possible to cover every aspect of CalAIM in a short period of time, just because of how massive it is. That said, I can talk about like the vision of CalAIM, why it is we're doing it, the main goals under CalAIM. I could also talk about how we are achieving CalAIM through various federal authorities, which are essential to us being able to implement. And then I could talk about a few specific components of CalAIM, specifically enhanced care management, community supports, and PATH. Providing access and transforming health. Again, this is not all of CalAIM. There are many other initiatives, but from sort of planning for this presentation, I got the sense that these are some key focus areas. But also I've included a number of links in these slides, and so welcome you to explore those if you're curious about these specific aspects of CalAIM or maybe what else we're doing. Simply because it's very exciting, and we are hopeful that it will be very beneficial to our program. So to start, let's talk a little bit more about the background, vision, and federal authority for CalAIM. And if we can go to the next slide, thank you. So again, CalAIM is a large collection of aligned Medi-Cal reforms that we are implementing over the course of the next several years. In fact, I think some further out aspects of CalAIM would not be going live until 2026, 2027. So it's very big and it's very transformative. These reforms essentially impact all of our different Medi-Cal delivery systems and our waiver programs. And they all ultimately support three primary goals. I'm not sure what happened. I had some graphics and they kind of turned into strange boxes, but these three goals essentially describe what we are trying to do with CalAIM, and all of our various CalAIM initiatives fall somewhere under these goals. First, we call out a whole person care approach to address social drivers of health, really caring for the whole person and envisioning our program as something that just doesn't happen in primary care offices or hospitals, but rather in the communities and homes and other community-based settings. Our second goal is really to improve quality outcomes, reduce disparities, and ultimately drive delivery system transformation here in California. And then last is to make a better Medi-Cal, make Medi-Cal more consistent, more efficient, and more seamless for our 14 or so million Medi-Cal beneficiaries here in California. So again, these are three large goals of CalAIM, and although we have a number of different initiatives that fall within this effort, they are all leading us in these directions. So slide 4, that's where we are now. Really, this just goes to show that in order to actually implement CalAIM, we rely on several different types of federal Medicaid authorities. These include our state plan. It also includes our new 1115 demonstration and our 1915B waivers, which we've titled the CalAIM 1115 and the CalAIM 1915B. It also includes a number of changes to our managed care contracts. And for just background, in case you all are not familiar with California's Medicaid program, we are largely, the vast majority of our beneficiaries receive their care through contracts with managed care plans. I think over 90% today, and likely 99% in the coming years, will receive their Medi-Cal benefits through through health plans, which the state contracts with. So that's just some background on how we operate Medicaid in California. So again, lots of different federal authorities at play, most of which are fully implemented as of the beginning of 2022. But there's more to come, and I'll talk a little bit about that in a second. But I also want to emphasize, one of the sort of goals with CalAIM is also not to just establish new pilot programs and test things. There certainly is some of that in CalAIM, but a lot of what we're doing, we intend to be permanent features of our program. And a lot of that builds off of previous waivers where we did pilot certain things, and that connects directly to the enhanced care management and community supports initiatives I'll speak to in a bit. But again, a lot of different authorities that we found necessary in order to make the broad reforms in this initiative. Next slide, please. Thanks. So this is just a reference slide where you could actually see our various documents tied to our federal authorities, including our just broad CalAIM homepage as well. But again, we authorized our CalAIM 1115B demonstration and our CalAIM 1915B waiver at the beginning of 2022, so effective this past January. This was sort of a new waiver. Previously, we were operating under what we called the Medi-Cal 2020 waiver. So we did have an 1115 and a 1915B waiver prior to this. And so CalAIM really represents what we were trying to accomplish with these new waivers. And so that is what we will be doing for the next 5 years. I believe this current waiver expires at the end of 2026. So again, these are good resources for you to see a bit more detail about how we structured these documents. And hopefully that'll be helpful. So let's go to slide 6. All right, so now is where I want to talk a bit more about the some key components of CalAIM. And so, I mentioned there's a number of initiatives under this, larger CalAIM initiative. I'm calling out a few in particular, which are more foundational and really highlight the goals that I discussed a few moments ago, those 3 broad goals of CalAIM. And I want to start with enhanced care management. And so while this is foundational to CalAIM, it's actually not something that we authorized or needed to authorize in our 1115 waiver. Rather, we're implementing enhanced care management as a managed care only benefit under our managed care contract authority. So our managed care delivery system is authorized under our 1915B waiver. And through our contracts, we're establishing a managed care specific benefit called enhanced care management. Enhanced care management, or ECM, as we often refer to it, is a person-centered and community-based care management benefit provided to the highest need Medi-Cal enrollees, and primarily through engagement in person where enrollees live, seek, and choose to access their services. Again, enrollees with the most complex needs will have their care coordinated by a lead care manager who are knowledgeable of community resources and the services that are available to coordinate that care for both medical and social drivers of health. And ECM is really our first statewide effort to address the complex care management needs. And it actually stems from 2 earlier pilots from our previous waiver, which are whole person care and health homes. And I mentioned that earlier. So again, essentially what we're doing with ECM and then community supports, it's somewhat of a carryover from our previous waiver, whereas in our previous waiver, we did this as sort of like a pilot project. Now we are implementing it statewide essentially taking the next steps and building off of the successes from those earlier programs. Next slide, please. Okay, so a bit more on ECM and what it is. ECM is intended to reach our individuals with the most complex needs, and these individuals often interact with multiple Medi-Cal delivery systems, different systems in which they're accessing their primary and specialty care, their dental care, their behavioral health, and their long-term services and supports. ECM supports both with the clinical and non-clinical needs of the individual. And again, and importantly, ECM is intended to be a benefit provided by specialized providers within the community. And I contrast that with some of the administrative sort of care management requirements that exist sort of with our health plans and the obligations that our health plans have to carry out. We have those in place for sort of individuals with lower levels of need. But for those highest levels of need, again, this is a benefit provided in the community by specialized providers, as opposed to a function of the health plans, I would say. ECM is not for everybody. It's for a defined set of populations of focus. For instance, individuals at risk or currently homeless, people with severe behavioral health needs. We have a sort of set of about 10 populations of focus who are eligible for ECM. And for those who are eligible for ECM, we have about 7 core service categories: outreach and engagement, member and family supports, health promotion, comprehensive transitional care, and a few others. And so again, this is all laid out in significant detail in the link that you can find at the bottom of the previous slide. But again, just highlighting how it really is for those individuals who have the highest need. And again, delivered within the communities. It's something that's very important to be successful with ECM. Let's go to the next slide. Community supports. So this is another foundational aspect of CalAIM, often kind of going hand in hand with enhanced care management. But community supports, like enhanced care management, is specific to our managed care delivery system, which again covers the vast majority of our population. Community supports are cost-effective alternatives to more traditional state plan benefits. And so things like housing supports or community transition services or medically supported food and meals, not quite healthcare services in themselves, but really important services that may help avoid more costly services down the road, like ED utilization or inpatient stays. Providers are serving patients that have complex social risk factors. They may have food insecurity or housing insecurity or homelessness. And we have about 14 pre-approved community supports that our managed care plans can essentially pick from to offer to their Medi-Cal members. It's important to know that these are not required, and these are not state plan benefits. That's just through the federal rules regarding in lieu of services, or what we call community supports. We can't essentially make health plans provide them. However, they are they can be selected by the health plans and provided again to hopefully avoid more costly utilization that they would have to cover. And again, I think there's a link at the bottom of this slide that will tell you a lot more about what each community support is. There is a large number of them, 14. But I do want to highlight the fact that, again, we cannot force plans to provide them. They are ultimately optional for both the plan to provide and also for the member to receive. Let's go to the next slide, please. I do want to talk a little bit more about community supports. So again, here's the entire menu of community supports. Again, just highlighting that these are alternatives to the state plans, so not state plan benefits, and elective for our plans to cover. And so they may be offered in different combinations or in different regions across the state. But we are doing things to incentivize their uptake, and have all of that available on our website, including which plans have selected, which community supports to provide. I wanted to highlight two, getting back to the federal authorities, because short-term post-hospitalization and housing and recuperative care are the only two community supports that we did require 1115 authority to authorize. And that is because of their resemblance to essentially room and board. It's not paying for rent at all, but it is providing a housing solution in certain circumstances. And for that reason, in our partnership with CMS, we learned that we had to actually authorize these two through an 1115 waiver. That said, we treat them essentially the same. We monitor them the same way, issue policy the same way. So it's really more behind the scenes. The federal authorities differ, but that's an important note. The other community supports are, again, authorized through our managed care contracts. Next slide, please. All right, so this is the last sort of component of CalAIM that I want to talk about before just kind of getting into questions and answers. Providing access and transforming health, what we refer to as PATH. This is extremely important to CalAIM, and it's a 5-year, $1.85 billion initiative that we did have to include this in the 1115 waiver. But the idea here is that it supports financially the sort of segment of California that needs to support CalAIM, but does not have a longstanding history with Medi-Cal, nor does it have the infrastructure or capacity to support CalAIM on a large scale. The work to support ECM and community supports, the community-based providers who are essential to it, they just simply haven't been as much of a part of our program until recently. In order to make them successful and to support their partnership with our health plans, we created this funding initiative approved by CMS in our 1115 demonstration, which will essentially build capacity and infrastructure for those essential community-based organizations to help them do Medicaid things like eligibility systems, billing systems, the things that they need to really play play a role in our program that they just don't have today and will require a lot of resources to build. And so that's the whole idea with PATH. It's funding to support all of these things that we want to do for CalAIM by building the capacity and infrastructure for the organizations that are going to be doing it. PATH itself has a number of different sort of programs within it. Some of that supports those earlier programs from our previous waiver. Those are whole person care and health homes, kind of helping sort of fund the gap between when those programs ended with the last waiver and when our managed care plans can successfully uptake all of the new CalAIM programs. But it also supports regional collaborative planning between community-based organizations, health plans, clinics, etc., to build those relationships. It also provides a technical assistance marketplace. So, new organizations that maybe don't have experience with Medi-Cal can go access technical assistance from this marketplace and do so funded through our PATH initiative. And then the last, it's really, again, the technical infrastructure, whether that be IT systems or new processes that need to happen with our community-based organizations. And then also supporting our CalAIM Justice Initiative, which I haven't talked much about, but is another important aspect of CalAIM and something we're wrapping up now with CMS. So again, with these bold ideas and ambitions of CalAIM, we also just understood that it's not going to happen without greater resources provided to these key organizations, and that's essentially what PATH is intended to do. And I believe that was the last slide. And so again, I'll just summarize. What I tried to convey is like the idea behind CalAIM, sort of, the importance of it to Medi-Cal, our sort of approach to authorizing the various components of CalAIM through federal authorities, and then highlight some of those key components that are really supposed to help our highest needs individuals and really expand their options to more community-based services as opposed to, costly EDUs, institutionalization, and things like that. But again, there is a lot more in CalAIM that we are trying to implement either now or over the course of the next several years. And so highly encourage you all to check out some of those links that I shared. And then also, if you don't have it, we could share my email address and you could reach out if you have specific questions. But again, this is not our only initiative, but certainly one of our largest, and it will keep us busy for the next several years. But still something we're excited about and something we think is going to make our program a lot better in California. And so let me pause there and see if there are any questions.
Great. Thank you, Aaron. Let's start with members of the committee. If you want to just raise your hand on the interaction and we'll go ahead with you. All right, Rachel, let's have you go first and then Stephanie.
Yeah, hi. This is Rachel with the, this is Rachel with the Association for Utah Community Health, representing the community health centers in Utah on the MAC. Sorry, I'm very tired. I guess we're doing a lot of, like, this reminds me a lot of kind of like the integrated care model and like the supportive services that the health centers currently offer to both Medicaid and uninsured patients and commercial patients as well here at the health centers. I'm wondering, it sounds like the PATH portion of this is a good way to support maybe areas of California that don't traditionally have as many community supports. Here in Utah, what I've noticed and what the health centers kind of struggle with is some of the rural and frontier areas don't have all the services that, urban areas have. So I kind of wonder if you can speak at all to, I'm not really sure how many rural areas there are in California, but what you've seen in kind of areas that don't have traditionally as many community supports to really partner with and reach out to and make this really work. Because that's just what I've seen, and that's like my main concern. But like, this is a model that we definitely really like and support.
Yeah, I mean, that's a great point. And I mean, believe it or not, we actually have a lot of rural communities in California, and we also have Los Angeles County. So we have a wide array of environments that we're all trying to support under the sort of CalAIM framework. And yeah, it's absolutely true. We have just different levels of abundance, different levels of sophistication throughout the state. And PATH is like a great way for us to maybe support some of those communities that don't have the infrastructure in place. I believe we have different ways. And first, actually, I should also say PATH is not our only funding effort. We have some other incentive programs and funding mechanisms in CalAIM. PATH is our large one, so I wanted to highlight that. But yeah, that's absolutely what we intend to do with PATH. And, understanding that in order to really, spread the uptake of these community supports, enhanced care management across the state the way it needs to be, there's going to have to be, greater investment in some areas as opposed to others. PATH funding is largely issued through a sort of like grant application process. And I believe we have some mechanisms in place to ensure that, we're sufficiently supporting our smaller and more rural areas in California. So I think, to your question, yeah, that's absolutely something that's on top of mind and something we have to deal with in California.
Yeah. Just one quick follow-up. Hopefully you can still hear me because my computer is bugging out, so to speak. Yeah. Did you have to were there areas where you just kind of had to like build up from the ground up some of these community supports, like they just didn't exist, so they kind of had to be created? That's my only follow-up there.
Yeah, I mean, to be honest, I'm not sure off the top of my head instances in which there was nothing and then something was created. I would point out that, I wouldn't necessarily frame it as something that our Department of Healthcare Services is creating. Rather, I think it's more about supporting what's in place, whether that be something that's in place there or maybe something that is in place elsewhere in the state and may be able to spread to sort of more underserved areas. So to your point, again, I don't know of a specific instance in where something was completely built from the ground up. It's certainly possible, but I think largely, in more instances, it's really about supporting and helping grow what might already be there in the first place. But again, I'd have to do some research. We should have some information on that online, I believe, as opposed to what's available where. I'm not sure if we just have instances of what you just described.
Yeah, okay, thank you so much. It's really helpful.
Yeah, thank you.
Okay, Stephanie, go ahead with your question, please.
Thank you. So I went, my name is Stephanie, and I'm a Medicaid member and advocate with and alongside other Medicaid members. I was able to go to a conference in Sacramento a couple months ago about CalAIM, and so appreciated hearing about it there as well. One of the things that was raised there that they really seem that they said is going to be something they're concerned about. I'm curious if there's been any more development on this, or if you could speak to it. But there's this whole idea of like, how do beneficiaries like self-identify, like to know that they have like these additional benefits, because it is like it is only for a certain population group, but like ensuring that they have like access to those benefits is really critical. And so I'm just curious if there's been any more just where things are at as far as like helping members to like self-identify and like recognize that they are beneficiaries and that they can access these additional benefits. And then also I'll pause there. I have a follow-up question though.
No, thank you, Stephanie. You know, I'm not entirely sure if there's any specific initiatives that have been launched in that direction under CalAIM. I would say we've done a lot regarding just our overall communications with the general public. I know that's not always intended. It's intended to reach our membership and not necessarily directed at them. But we've done a lot in like the communication space, not necessarily part of CalAIM. I know we're doing some work to really just build out better outreach and integration of our member voices into our program with some other things that we're doing here in Medi-Cal. But to your specific question, I'm not sure if there's anything in particular that I would highlight. There are a number of requirements regarding, you know, making our members aware of what's available to them. A lot of that happens through our managed care plans. So there's some basic requirements for that. But again, specifically, I'm not sure if I can call out like a specific sort of effort or initiative that's, you know, developed since you last heard about it a few months ago.
Okay, thank you. I guess my next question is, because this is giving a lot of responsibility as well as a lot of funding over to the managed care plans. Did you all go through like a process to strengthen like the contract language to like ensure that like, and I guess, are there pieces of that you're willing to share as far as like how to structure contracts in a way that really do require enough accountability on the health plans? And then also like, are there any unintended consequences that you're looking for? And yeah, maybe that would be my follow-up questions. Thank you for your time.
Sure. I think there's a couple ways or a couple things I would highlight there. I would say just in terms of like our contracts with plans, I didn't touch on it during this presentation, but another major effort of ours that we're still in the middle of, but have done a lot of work already, is actually to re-procure many of our managed care contracts. And so I didn't include it in any of the links that I shared today because it's somewhat of a different topic. But there's a lot of information on our website about that procurement and sort of our goals with the procurement. Again, it's the largest one I believe we've ever done in a singular event. But a lot of the goals, or many of the goals, were to overhaul our contracts with managed care health plans, kind of like you said, really ensuring that there's accountability, better outcomes, and other measures that we believe will make our program more successful. So not quite specific to what I've just talked about today, but just more globally, our approach with the health plans. A lot of that is anchored on our new procurement. And I believe everything's underway for that to go forward in January of 2024, if I'm not mistaken. So I would really encourage you to look at our reprocurement, maybe the strategies that we employed there. It's on our website, and I could work with the facilitators of this meeting to share some more specific links on that. Another thing that we did more specific to ECM and community supports, knowing that this would bring a lot of new types of organizations into the mix, who would have to work with and contract with managed care plans. We issued a lot of guidance to kind of foster that process, guidance on billing, guidance to help sort of these new organizations understand what it means to contract and work with managed care plans. So that's one way in which we tried to foster and support that relationship specific to ECM and community supports. And then again, just to recap, our sort of more global approach with managed care plans, I think, is anchored around our reprocurement effort, which is still ongoing. So I hope that helps. And I didn't quite answer your question specifically, but that's what I would offer.
Thank you. Oh, and I think the other part of the question was just, are there any unintended consequences you're looking for?
I mean, certainly whenever we do something like this, there could be unintended consequences. I think we're trying to, through these funding initiatives like PATH and some others, do our best to ensure that we're creating policy that's actually something that can be implemented within the community, and using financial resources and distributing those to be as successful as possible. As far as unintended consequences, nothing really comes to mind right now. But again, it's a major change for us, and so we do have to closely monitor it. We'll have a lot of reporting requirements to the federal government that comes with these waivers and demonstrations. So there will be a lot of work, just both on a more acute monitoring perspective and then on a long-term evaluation to see how effective we were. But in terms of, again, no specific unintended consequences come to mind, although I'm sure there's the possibility for them with a change like this.
Okay, thank you. Are there any other questions from members participating in the meeting, even beside members of the MAC? Just other attendees who have a question? Yes, Ron. It looks like Ron's dropped off. So Andrew, let's go to you, and then Representative Dunnigan.
Thanks, Michael. Hi, Aaron. My name is Andrew Riggle, and I'm with the Disability Law Center, which is Utah's Protection and Advocacy Agency. I just had a question. You mentioned that for short-term hospitalization transition work that you have been doing, and that you discovered that you needed to do an 1115 in order to provide something similar to room and board for that. I was wondering if there are any limitations around that, like how often you can provide it, or for how long you can provide it to an individual. If there are any exclusions around that, or so any light you can shed on that would be helpful.
Sure. Thank you, Andrew. And so I think that's getting into a level of detail where I'm not a subject matter expert, but I think if you go to our community support slide, I included a link at the bottom. If you go to that link, what you can find is a community supports policy guide. The community supports policy guide will lay out each of the 14 services and provide that level of detail that you're asking for. So like, what does this really mean? When is it available? What are any limitations? So again, apologize, I can't go through that off the top of my head, but certainly if you follow that link and look for the community supports policy guide, you'll get like a ton of information on each of these. And I think that should answer some of your questions.
Will do. Thank you very much.
No problem. And we also have an ECM policy guide on that same page too. That's where we're going to find the most available detail we have on these initiatives.
Okay, Representative Dunnigan, let's have you go next. Thank you.
Thank you. This is Jim Dunnigan. I have a question on your housing support. So housing's a real challenge for us. It seems like you said or indicated that you can have your managed care providers assist with the first and last month's rent, but it's not, or we don't want to call it rent. It sounds like rent, but we don't want to call it rent. So deposits, but you don't give them any additional money to do that. Is that true? Is there, how do they get reimbursed? Is it just part of their capitation, or how do you reimburse them?
So in terms of how do we reimburse the plans, yes, I believe our community supports are built into our capitation rates. If I'm not mistaken, I'm not the financial expert, but roughly that's how it works. It's built into the rates, as opposed to like a fee for service payment. Yeah, you're right. Our housing supports, one of them at least would include, I believe, first and last month's rent and maybe some other financial support. But again, it's not like monthly rent. We also cover some housing navigation services. So yeah, that's provided by the health plan. They take on the community supports, they offer that to their members, and then our reimbursement through our health plans is through a capitated basis and through some financial mechanisms. It's factored into that.
Do you know if that housing support can be done on a fee-for-service basis? Because for me, I mean, it's exciting if we can get them even the first and last month's rent. That's significant, plus navigation. But if the providers don't get reimbursed any additional for them, why would they do it? Because that's competing with any other type of treatment or support they could do.
So I can jump in here. I've actually seen a couple of presentations on this and was very curious on it as well. And so Aaron, you can correct me if I'm misstating this. But I think one of the key aspects of this whole reform was CMS authorizing Medi-Cal to include these in lieu of services as being reimbursable if they include them in the contracts with the managed care plans as optional services and have them written into the contracts, where in the past in lieu of services were not able to be incorporated into future rate setting. CMS is, through this type of a new initiative, allowing these additional wraparound services or community supports, as they're referring to them, to be paid for by the managed care plans and then have those payments included in their future rate setting as if they were a medical claim. And then the plans collectively are able to get that money reimbursed through future rate setting. So I think that's an important part of this reform. And that is why it does have to be through a managed care entity as opposed through a fee-for-service provider.
Yes, thank you, Michael.
So do the providers or the managed care providers have to kind of eat it, because it's only then reimbursed in future rate settings when they're going to be probably providing additional housing supports then?
Yeah, I mean, again, it's ultimately up to them if they're going to take this on at all. They have complete liberty to not take these on. It's I don't like the nuances to the rate setting and how this factors in is kind of well beyond me, so I don't want to get too far into it. But again, there's that premise here that through adopting and providing these community supports, they may be able to, again, avoid some of those more costly Medicaid services that they are financially accountable for as well. So again, that's the concept, and they have the option to take it up or not. But all the financial considerations, I wouldn't possibly be able to assume at the health plan level. And I'm also not sure. I fully agree with how Michael described it, but I don't recall if we had ever even considered doing this as a fee for service. Again, our program is a vast majority of it delivered through managed care, and so that's largely where we lean to implement these things. It's not that we don't have a fee-for-service population, we do, but again, our program is largely administered through our managed care plan contracts.
Thank you. Michael, do you know if it's prohibited on fee-for-service?
Well, the presentation I had was through Manat, and Cindy Mann, the former federal Medicaid director, was facilitating the call. And they were talking with the CMCS director, whose name I'm blanking, but he's I think Daniel Sy, former Medicaid director in Massachusetts, and he was talking about the approval. And it seemed like the managed care was the critical piece in the whole equation, that it was only through contracted managed care plans that they were offering this, and it wasn't through fee-for-service. I think it's something that could possibly be explored, but that seemed to be an integral part of this whole operation, was those in lieu of services. And by putting them in the managed care contracts, that allowed future rate setting to include payments. But I do think it could allow the actuaries that would build up even prospective rates to incorporate that in the rate setting assumptions, to work with the state on what baseline level of expenditures they would assume and have that accounted for in the rates going forward. So I'd be happy to talk with you later if you have more questions.
I'm interested in this, especially if it can be built in prospectively. I see that others want to comment, so I will end right there. Thank you.
Okay, thank you. Ron, you have a question?
Yes, I do. So my question is how Medi-Cal, how California contracts, how do you make that competitive for the service providers to provide the best care, the most high quality service at the best value for California taxpayers?
So we have a number of incentive programs that we are implementing. I gave the example of PATH, but we have a few others, some specific to some specific to ECM and community supports. And so there's, like other incentive programs, measures that have to be met, various other requirements where we need to see, demonstrated results in order for those incentives to be paid. And so I think that kind of underlies a lot of what we're doing with CalAIM. Again, in addition to the sort of concept that by providing ECM or taking on community supports, these services can be provided at a cheaper cost and may, prevent, costly stays, costly ED utilization down the road. I mean, that's kind of like the premise. So I would say, that in addition to our various incentive programs and, the requirements to sort of demonstrate, successes is sort of how we're doing that. I think there's a lot more that I'm not mentioning that comes into play on the sort of bigger sort of financial picture with CalAIM and these specific initiatives. But again, it's really more about providing, better value care and not just simply, more care. I think that's really a fundamental goal of CalAIM. And we do have other instances that I didn't cover. What comes to mind is specifically what we're doing in our behavioral health delivery system, which it really is moving from just kind of like cost-based reimbursement to more value-based reimbursement. So that's another part of CalAIM that I didn't quite cover today. So I think there's a various set of ways we're doing that to make it, financially beneficial as well.
All right, one final question, Emma.
Actually, Michael, thanks. I was going to just build on what you and Aaron have already said. This is very similar to the B3 services that we've had built in our behavioral health contracts for many years. There are services that the behavioral health, the PMHPs can provide to their enrollees. They are not actually reimbursed for them, but they do get credit for them in future rulemaking. And so Utah has done something like this on a much smaller scale. And the whole concept is that by using these services and better managing the care, the plan will actually get savings, and that's what helps to pay for these services. So just wanted to throw that out there, that Utah has had a little bit of experience, but not anything as significant as this. And one other comment in response to Representative Dunnigan, to do this on a fee-for-service basis would mean that this would have to be a service that is reimbursable on a fee-for-service basis statewide, and the state would have to accept any willing provider who could provide these services. And so it definitely has a larger fiscal impact to do this on a fee-for-service basis.
Right. Okay. Well, thank you, Erin, so much for your time. We've definitely taxed you beyond the 30 minutes you had obligated for being here, but obviously a lot of questions, very innovative and exciting program you've got developed, and we'll see if there are additional questions and send them out to you, and appreciate all of the resources you've offered for us to explore this further. So thank you so much for your time this afternoon, and we'll let you go ahead and drop off.
Yeah, thank you all for having me again. Feel free to share my email address, and we do our best to support other state Medicaid programs. So if there's a question I couldn't answer for you today, then if you can get it to me, I'll see what we can do.
Great. Thanks so much.
Thank you all.
Okay, let's go back to our first item on the agenda. Dr. Brenton, are you on the call?
I haven't seen her join, Michael.
Okay.
So.
All right. Well, we would like to welcome Dr. Jennifer Brenton, who is our new MAC member representing the physician community. And so she is newly appointed to the MAC, and we appreciate her. She's, again, representing the physician community. That position has been held by Dr. Cosgrove for the past several years, and so we'll look forward to working with Jennifer in this capacity. Do we have enough of a participation for a quorum to take action on last meeting's minutes?
Yes, we do. We do.
Okay.
So we can do that. Thanks.
Very good. So hopefully everyone's had a chance to review the minutes. I would be happy to entertain a motion from any of the committee members to approve those minutes.
Michael, this is Brian. I can move.
Okay. Any second to the motion from Brian?
This is Rachel. I second the motion.
All right, thank you. And then we'll go ahead and assume that if nobody else has any opposition, that the meeting minutes will be approved. But if you have a concern and don't want to approve them, just mention that right now. Otherwise, we will proceed as if they're approved unanimously. Okay, thank you. So we will consider the October meeting minutes approved, and we will move on to item number 3 on our agenda, public hearings. Laura gets to inform us on 2 new 1115 waiver amendments, and we'll be taking public comment on both of those amendments, I understand. So Laura, we'll go ahead and turn some time over to you.
Great, thank you, Michael. It was interesting to hear some of what's going on with California's 1115 waiver and other initiatives. So we'll now transition and talk about a couple of things going on with Utah's 1115. I'm Laura Belgique. I manage Utah's 1115 demonstration, otherwise known as the 1115 waiver. And as Michael mentioned, part of today's meeting is a public hearing for 2 1115 amendments that will be submitted to CMS this month. The public comment period began November 24th and goes through the 23rd of this month. And today I will be presenting a summary of the 2 amendments and then opening it up for comment. You will have the opportunity today during this meeting to offer comments, and then you can also provide them through the end of the public comment period. And you can do so through our website, the 1115 demonstration website, which is provided on the summaries, which I will now review. So I will go ahead and go through them both, and then we will open it up for public comment. So the first is integrated behavioral health services. This is a result of Senate Bill 41, which was run in the 2022 general session, titled Behavioral Health Services Amendments. This amendment seeks approval from the Centers for Medicaid and Medicare Services to allow individuals to receive existing state plan covered physical and behavioral services in an integrated model through a contracted local mental health authority, which will be selected through a request for proposal process. In terms of the eligibility, Medicaid eligible individuals under this demonstration must meet the following requirements. Members who are served by the contracted local mental health authority who access services through the local mental health authority. In terms of benefits, if approved under this demonstration, qualified Medicaid members will be eligible to receive the following services. Qualified members will be eligible to receive existing state plan covered physical and behavioral services through the local contracted mental health authority. As far as the proposed demonstration timeframe, we intend to implement the proposed benefit as soon as possible after approval, but not before January 1st of 2024. And the population impacted, we expect approximately 250 individuals to be eligible if the amendment is approved. And Sharon, if you don't mind going to the second amendment. Okay, so the second amendment is titled Long-Term Services and Supports for Behaviorally Complex Individuals. This amendment is the result of the Governor's Office of Planning and Budget requests. This amendment seeks approval from the Centers for Medicare and Medicaid Services to provide long-term services and supports to individuals who have behaviorally complex conditions. In terms of eligibility, Medicaid eligible individuals under this demonstration must meet the following requirements. Members who have more than one complex medical, organic, cognitive, and psychiatric and behavioral conditions that result in difficulty finding appropriate long-term services and support options. In terms of benefits, if approved, qualified Medicaid members will be eligible to receive the following services: the ability to receive rehabilitative services in a skilled nursing facility with professionals who are licensed to provide care to individuals with substance use disorder, severe mental illness, or other behaviorally complex conditions. As far as the time frame, we intend to implement the proposed benefit as soon as possible after approval, but again, not before January 1st of 2024. And finally, in terms of population, we expect approximately 50 individuals to be eligible if this amendment is approved. So we will now open it up for comment.
Yeah, I know I have some questions, but let me open it up to the members of the MAC and see if they have any clarifying questions before we take any comments. Okay, any clarifying questions from the public? Andrew.
Hey, Laura, I know it will probably come as a shock, but I have three clarifying questions for you, if that's okay.
Sure.
The first one is wondering if you could the population eligibility for the behaviorally complex amendment seems rather broad, and so I'm wondering if you have any more detail that you can offer about who would be eligible for that, and how would their eligibility be determined is number one. And then number two is, would this be, it reads like it would be a contract with a single facility to do this. Is that correct? And then the third question is, how I believe that there is some intent in the language that this would be somewhat of a short-term placement. Number one, is that correct? And then number two, how what is the thinking about how long somebody would be served under this program, and how would the transition out of the facility based side of this occur?
Okay, let's see, we can take those one by one. And Brian, are you okay to speak to Andrew's questions?
Yeah, I am, and I'll probably answer them in order of the easiness to answer for me, if you don't mind. So, your question number 2 about it being awarded to a single entity, yes, that was written into the intent language in the funding that we would go out to RFP for a single entity. So, yes, that is the intent. Number 3, you asked, jog my memory a little bit on that, if you don't mind.
Sorry, Brian. It was number 3 was it's my understanding, at least from what's provided in the language, that this may be intended to be kind of a short-term stabilization type option, and so is my interpretation correct? And number 2, if so, how would transition when would transition out of the facility occur, and how would that occur?
Yeah, so it is a good question. So it is designed to be a somewhat short term. However, we're not writing into the waiver any specific boundaries. We're envisioning a tiered rate structure. So rate for the first 60 days, and then a lower rate for days after that, with the goal to transition members to the community. This would not be envisioned as a long-term placement by any means. So community placement would be a goal. As to now, if I can get back to the first question about like the broad eligibility, I think the intent is to serve individuals that require multiple specialties in a single setting. So some substance use disorder counselors, mental health counselors, psychologists, perhaps a psychiatrist, although I don't have all of those notes in front of me. As of this stage, we are probably keeping it fairly broad for CMS authority, and then we would refine it a little bit when it comes to the contract setting. But we would welcome feedback on that at this stage. That's the whole purpose here. So we would welcome that feedback.
Thank you, Brian. Michael, is it okay if I ask Laura one more question?
Yes, but this might be your final question for the day, Andrew. So ask wisely.
Make it a good one, okay? And that is Laura. Are there from our experience, there don't seem to be a whole lot of skilled nursing facilities that have a lot of staff or expertise with folks who have cognitive, intellectual, behavioral, or psychological psychological needs. So, is it the state's sense that you can find a provider a skilled nursing provider who is able to provide all of the necessary supports in a setting, or how how are the unique needs of this population going to be addressed in a skilled nursing environment?
Yeah, so again, a good question. I mean, the intent of the funding is to allow some capacity building by a skilled nursing facility. So I think I agree with you there that absent this funding, not many have the capacity to serve these individuals as is. So some of you may remember, I think this originally came through the Medical Care Advisory Committee more than a year ago. A particular skilled nursing facility presented an idea for this, but the state, and they presented that with a certain amount of funding, they could do it. We got the funding, we would get CMS authority and then a competitive procurement process to follow. But our idea is that we would be able to find someone through RFP. Thank you for your questions.
Okay, question from Ron Farber.
Yes, I guess I wanted to elaborate a little bit more on what Andrew had mentioned about rehab versus long-term care. I guess our concern is that if an individual is renting an apartment, goes to the hospital, is transferred from the hospital to an LTSS facility, you know, just in a few months, they're going to lose their apartment. And if they're medicated at the facility to a point where they don't have proper judgment, this doesn't always happen, but we see it quite a bit. I think we're afraid of this being institutionalization and folks losing their civil rights. Are they able to leave the facility at any time? Is this considered an institution? How will other programs interact with this program, like the New Choices waiver and some other programs where we can get them? I mean, it's called community-based, but it's really, I don't know if it's community-based. So we're really concerned about a lot of issues, and a lot of our folks who are medically complex, they're afraid of being institutionalized. So I think there's a lot of work. If this is going to be implemented, man, there's a lot of work to be done, and clarification that people's civil rights aren't being violated. But I guess my question is rehab versus long-term care. Again, it alludes to what Andrew has said. How long is rehab going to take place? Thank you.
So thank you for the comment. I would probably hold some of that as like for a more formal response. But I can mention a couple of things that, as you may know, our New Choices waiver does not have a waiting list. If you meet the level of care, individuals can transfer to the New Choices waiver upon meeting that level of care. So, and that will remain. So nothing more I have to add about the length of time. We're not writing it in, but there is, I mean, we hold the same value in having people in the most individualized community-based setting available to them that meets their needs. But we would welcome your feedback and public comment through this process, and it will be submitted with our waiver.
So I think those questions that were asked kind of include some public comment in terms of concerns about people losing their freedom or their civil rights and choice, and just wanting to make sure that the structure of this ends up ensuring that people have a choice to have a community-based alternative, or at least have that in consideration as part of the proposal is something I'm taking away from this that I think we should consider as public comment, if that's fair, Ron and Andrew, to summarize that. Okay. I have some other questions. I won't get to all of them because we could spend the whole time on my questions, but I think Andrew and Ron have asked and you've answered some of my questions on the medically complex waiver. So I'll just focus my questions on what's being called the integrated behavioral health services. Looking through your content on the internet for the 37-page detailed amendment submission, it looks like, despite saying this is an integrated benefit, your per member per month is estimated at like $67 per member per month, and you're targeting 250 individuals, which seems like it's, based on the narrative, focused on additional primary care services. And I'm trying to figure out how extensive those primary care services are, because you're issuing an RFP for a prepaid mental health plan or a county-based behavioral health system to offer what's being termed integrated behavioral health care for what you're estimating to be 250 people. And I'm curious about the extent of the benefits, because that seems like a pretty limited integrated benefit, focusing on a limited part of primary care. And it doesn't look like there are any geographic limitations in the waiver. So recognizing, I think, as I watched this legislation come through the session, it was discussed as a rural project where we might be able to get some better integrated services between physical and behavioral health where it's not available. But it doesn't look like there would be anything from preventing a Wasatch Front-based prepaid mental health plan from bidding on this and getting 250 people, if that would work out. So how would you see that overlaying, say, the UMIC contracts and the ACO contracts with the overlapping footprint in the urban settings? And again, the question about the extent of the benefits that's being presented as integrated healthcare.
Yeah, good questions, Michael. So by my read, Senate Bill 41 has no restrictions on location. It just requires us to produce a RFP for one local mental health authority. And we are not envisioning that this would replace our UMIC plans whatsoever. This is just to allow additional physical health primary care services to be delivered on site in that setting. It was a relatively small appropriation, $200,000, and so we can kind of, that's how the math was done to back into about what we know from some interested local mental health authorities about how much they would serve. And so essentially divide the appropriation by the number of people that they estimated could be served by that. And so again, this wouldn't, it would be for some primary care. This would not, it's not our expectation that specialists would be provided here, physician specialists, laboratories, maybe some minor labs to be performed, but
and that would be contemplated based on the response of those bidding on the RFP, presumably. But I'm just curious about the potential confusion for the member who might be saying they've chosen, let's say, a county such as Tooele, well, let's use a different one. Let's say you went to county bids on this and they are awarded the bid, and they're, I think we've got Northeastern is the prepaid mental health plan out there. And then you had some voluntary enrollees in an ACO for their physical health. And then if the individual was getting this primary care in the behavioral health setting, you don't think there would be potential confusion about providers billing the ACO for those services, and how are they going to know who to send the bill to? I think that's my public comment, is just as you go through the RFP process, just looking from the member's perspective at potential confusion of their existing delivery system, and making sure there's clarity both for the Medicaid enrollees and the provider community about who's responsible for what parts of the system, because it's already super complicated for most people on the outside observing a lot of this. And I think that would just help in terms of making sure we have clarity. And if the idea is to test an additional benefit embedded within primarily a behavioral healthcare setting, if that's additive, and what that would look like as an enriched benefit as opposed to some of the other delivery models that are already tested or implemented. So that's my comment.
No, I appreciate the comment. Yeah, I mean, anything to prevent confusion, we would certainly take into advisement. I do think that the fact that we are selecting through bid a provider to contract with for this benefit, I mean, I get the point. We wouldn't want other physicians in that county or area to be confused about who they bill. But we will take that comment. I think it's a good one. Thank you.
All right. And then are there any other comments right now on the two amendments that people would like to submit? If you don't have it formulated, we can come back to this later in the meeting and you can speak to it again. But we'll just ask right now as well. Okay, Laura, looks like you're done for the minute. Thank you for your presentation of these important policy considerations and giving members of the MAC and the public in general a chance to comment and at least better understand what's being proposed.
Thank you.
Okay, director's report. Jennifer's not with us, so Brian has been asked to pinch hit, so we will put him to the plate and have him go through his material for us. Thank you, Brian.
Yeah, thank you. More speaking than I get to do most meetings. So Brian Roach, Assistant Division Director here with Division of Integrated Healthcare. Wanted to update MAC on a few items of interest. So first, PRISM, we've just passed a pretty important milestone where we've gone through the vast majority of our user acceptance testing and parallel testing. So at this point, we are getting to what we call our soft go live date of January 2023, which is essentially our thumbs up that PRISM is ready. We've delayed the hard go live or provider go live to April 2023, which is when all of the claims processing and other elements of PRISM will go live. And that delay allows us to go through substantial training for our provider community through multiple methods, online, live, recorded sessions available for providers. And more information is being rolled out through our MIBs and other communication avenues like this one. An important thing to keep in mind is our freeze period will happen from March 13th through April 2nd. That allows us to convert the large amount of data from our legacy system to PRISM and without any missing pieces in the interim. So it allows us to pick up the data from the old system and carry it forward in the new system. More information on that freeze date will be forthcoming as well. Next, in policy updates, wanted to give an update on some RFPs that are in various rounds of approval. Our managed care dental RFP has been awarded to the incumbents, so that is completed. Next, the pharmacy point of sale is still under review and advancing towards a decision by the RFP committee within next few weeks. Our non-emergency medical transport contract is being finalized with Motive Care. The current contract ends the end of January, and we're going through some final negotiations with Motive Care right now.
Ryan, let me just stop you. I didn't hear. On the managed care dental, you say it's awarded. Have you named the two or the dental managed care providers, or did I just miss that?
Eric, can you speak to that, please?
Sure. So it was awarded to our two existing providers, so that's Premier and MCNA.
Okay, so no change for beneficiaries in terms of their experience there.
That's
Thank
correct.
you.
Thank you. Okay, so next, our Autism Spectrum Disorder Service Manual is being updated effective January. This has been a labor of love that we've worked on for many months now, and we should see a lot of improvement here. Some better alignment of the manual with established rules. We had come to an understanding of some contradiction with other licensing rules. For example, the manual will help reduce a lot of that confusion with our providers. Updating some billing codes to allow providers more flexibility in billing, and removing some prior authorization requirements. As an example, prior authorizing the initial determination assessment for autism services is being removed. Moving on, our dental hygienist policy is going live January 1st. This was first authorized in the 2021 general session and just coming live now. So hygienists that are billing through managed dental organizations may begin billing in January. And we have allowed them to begin enrolling as Medicaid providers recently. I don't know the exact date off the top of my head, but they'll be able to enroll, deliver services to members in public health settings, such as a school, a nursing facility, or a local health department. And then, like I said, January 1st, they can bill managed dental organizations. When they're delivering services to a fee-for-service member, they can bill as of April through PRISM for services delivered from January forward. And we are releasing the procedure codes that are eligible to be billed for those hygienists in our December interim MIB that should be released shortly, probably next week.
Hi,
Moving
this is
on.
Destiny
Sure.
with Premier Access. If I can just jump in, since you said they can start billing the managed care entities in January, that's actually not exactly correct, because we cannot pay them until they have a Medicaid ID. So they won't be able to receive payment from managed care or from the state until they go through the approval process and receive the Medicaid ID from the state. So there will be a lag there. So I just wanted to clarify that. We aren't able to pay the providers until they're approved in the PRISM system.
Yeah, so definitely it was my understanding that we've already begun allowing hygienists to enroll. It's just our legacy system will not allow the billing encounters to be received. So that's, we would wait on receiving the encounters, but perhaps we just need to touch base after this and clarify that. So,
Okay, yeah, that would be good.
Thank you for your comment.
Okay, thank you. We don't want anyone to be confused. Thanks.
Sure. So yeah, we'll clarify that. Thank you. Next, a new initiative to allow pharmacists reimbursement. So there has been state law recently to allow pharmacists prescribing of oral contraceptives, but what would change now is the reimbursement for counseling related to that. And beginning January 1st, 2023, we will begin a $20 reimbursement for that. We will reimburse through point of sale system when the appropriate diagnosis is attached to the dispensing of contraception. A self-assessment questionnaire is required in the process, and then we would have a limit of once per year for that counseling reimbursement. If a pharmacist provides the counseling and it does not result in a dispensing of contraceptives, then there would be no reimbursement for that. And sometimes in certain circumstances, it may result in a referral to a specialist physician. So the pharmacists, as I understand it, are well aware of that and have the referral networks in place. Then moving on to some other 1115 waiver updates. As I think this community knows, our non-traditional benefit plan is sunsetting, and the official date of sunset will be January 1st, 2024. All of those individuals will start getting a traditional benefit plan. Our medical respite service waiver, we are anticipating CMS approval soon. I would be hard pressed to give a certain date, but we're hoping within the next couple months. And essentially this will allow individuals transitioning out of a inpatient setting who don't have stable housing to receive something less than nursing facility level of care, but would receive something equivalent to home health services, skilled nursing in a stable environment, while they can get some stability in housing arranged for them. And we will work with we will work to procure a vendor once we have CMS authority for that. Other news, last week we met with the Behavioral Health Delivery Working Group, discussed some operational concerns, and our next meeting will be February 3rd. Our housing-related services and supports will begin some billing capacity either this month or next month. We received CMS approval of that back in August, and we've been working to design our provider manual, our prior authorization pathway, the needs-based criteria, stuff like that. And we're about ready for implementation. Our medically complex children waiver, we have been working to expand the enrollment based on House Bill 200 earlier this year. We're working to add 130 new recipients to the medically complex children waiver. We've received 167 applications last time I checked, and they will be admitted according to their acuity. Next, some things in the future to look forward to. We want to continue to improve the Medicaid application process. Things that are going to be worked on in the near future are video and step-by-step companion guide for the Medicaid application process in multiple languages, scheduled to really be developed after the new MyCase system is launched in the first quarter of next year. So I will catch breath and take a glass of water, but any questions or feedback?
Any questions from the members of the MAC? Any questions from the public? right, Brian, looks like you're done for a few minutes at least. I'm sure we'll find a way of roping you back into the meeting, but let's move on to Eric Grant and his summary of the governor's budget proposal that just came out last week.
Certainly. Thanks, Michael. I don't know who's presenting. I'm going to present my screen. I've got a tiny PowerPoint that I've just put together to kind of walk through each of the items. So as Michael mentioned, the governor's budget was released last week, and we've had a little bit of time to go through it. We're very pleased with what has been provided to Medicaid and the consideration for Medicaid. Just reminding the members of the MAC and all those in attendance that although these things are in the governor's budget, they still have to be approved through legislation. So diving right in. See if I can get my slides to advance. Okay, so we'll start with the one-time recommendations for the state fiscal year 2023. The first item and only item for 2023 is our Medicaid consensus process. And for those of you who are not familiar with this is a process where we meet a couple of times a year with the legislative fiscal analyst and the governor's office of planning and budget to try to ascertain the needs of Medicaid. Part of that is we all make our own projections of eligibility and utilization, and then we come to a consensus agreement as to what we think those estimates should look like. So for state fiscal year 2023, we will be returning $41.8 million back to the general fund. The primary driver for this is the continuation of the public health emergency. And along with that public health emergency continuation, we continue to receive an enhancement of 6.2% to our federal match for Medicaid services. And so with that, we'll be able to return some money to the general fund.
Quick question on that, Eric. Does that assume the public health emergency funding only went through December, or does this go all the way into March?
So at this point, I believe this went through March. And so we'll be making adjustments in January or in February consensus to adjust it all the way through June.
Assuming that the PHE is going to be extended because no notice has been given that it's ending in the middle of January.
Right. It's kind of magical because we, as some of you may know, we've been given assurances from the federal government that they will give us a 60-day advance notice of when the PHE is going to end. So the PHE was scheduled to end on January 11th. The 60-day period of time has come and gone. Now, that doesn't preclude them from giving us a 60-day notice, say, tomorrow or anytime in the near future. But all indications are pointing to that they will do another 90-day review. One of the strongest indications is the Congressional Budget Office, who's estimating that the 6.2% FMAP enhancement will continue through June 30th. So as a result, we're feeling fairly comfortable that the PHE will likely end in April.
Okay, thank you.
You bet. Okay, so let's move on to recommendations for 2024. These will include both one-time and ongoing items, and I'll point those out as we go through. So again, Medicaid consensus. In 2024, we'll be receiving $21.1 million one-time funding, and a lot of this is also due to the public health emergency and the unwinding of Medicaid eligibility. As part of the public health emergency, anyone who was eligible for Medicaid benefits in January of 2020 was required to be held on the program as a maintenance of effort requirement. And so after the public health emergency ends, we will begin unwinding those individuals. And so this one-time funding is to help cover the cost of those individuals without the 6.2% enhanced FMAP that we will be receiving. In addition to that, we are receiving $44.2 million ongoing. And again, these are based on that Medicaid consensus process that happened in October prior to us really knowing what was going to happen to the PHE. So it's very likely that the next consensus will make different recommendations than these. But at this point, these were what were included in the governor's budget.
And just as a note, EAC adopted these on Tuesday, and so they should appear in base budget bill legislation that would appear in the first week of the session we're anticipating. Yes?
I believe so. I talked to the LFA about that today because they've sent us the first draft and they didn't appear in there. And so I think you're right. I think we have to wait till ESC does adopt them and then they will appear in the base budget bill. So, all right. The next item that was included in the governor's budget was $800,000 ongoing funding to increase air ambulance transport rates. And so this basically, we've been looking at this and looking at what other states are paying. And so this funding will likely bring us closer to what our surrounding states are paying for these services. The next item is family planning services. We would be receiving approximately 400,000 ongoing, with a one-time reduction of 163,000. The purpose behind this is to provide family planning services for people above the normal Medicaid limits. We're anticipating we'd be able to receive 90% federal funding for these services because they are related to family planning. We'll be required to apply for a waiver for this program. And based on that, we anticipate that with the application of the waiver and getting CMS approval, we're targeting a January implementation, hence why the one-time give back that reduces the amount for that first year in order for us to have time to get the approval from the federal government. Next up, we have intermediate care facility payment rates, 2.2 million ongoing. This is a rate increase for ICF facilities. It's somewhat related to the settlement from the Disability Law Center that was approved in House Joint Resolution 28 in the 2019 General Legislative Session. The idea behind this are that people will be transitioning out of these facilities and going into community-based settings. This backfills that funding to keep these facilities functioning at an appropriate level. Next, we have Medicaid annual WellCare visits, 247,400 ongoing. These funds will expand coverage of primary preventive services to include the adult Medicaid population. Next, we have coverage of community health workers, 300,000 ongoing. This will add community health workers as an authorized provider to deliver services to Medicaid recipients. Next, we have 12 months postpartum coverage, 2.9 million ongoing. This funding will extend the coverage. Right now, we only cover 60 days postpartum, and this will extend that coverage to 12 months.
Question on that, Eric.
Sure.
So with the Medicaid adult expansion that's been in effect for the last several years, I am kind of curious about what would be different for a pregnant woman under this coverage versus just leaving the category of pregnant women and moving into this enrollment area for 12 months as opposed to coming off and just moving to the adult expansion.
Sure. I think Brian's eager to answer this.
He is. He didn't get to talk for 5 minutes and now he wants back in the show. Look at that. See, you love it, Brian. Here we go.
For sure. And I actually see Representative Lesser on the phone. I think she may have an opinion on this as well, which I would welcome. But so you're right in principle, like the income levels are similar. So our pregnant woman program covers up to effectively 144% of the poverty level, and adult expansion covers up to 138%. A little bit of gap there, and there's also the ability for a pregnant woman during pregnancy to change their FPL and get higher FPL. One thing so we still see about a third of pregnant women after postpartum that would lose eligibility after 60 days, even in an expansion environment. Now, they're kept on the program today due to the public health emergency, but after that ends, they would not. But even for the other 2/3 that are not affected, it would essentially mean no application needed to work through in the 60 days postpartum, giving them a longer period of time, no potential plan disruption during that period of time.
Need to report a change of income during that period of time.
Right, exactly. Some certainty. Yep.
All right, well, that's good. I just think it would be helpful for everybody on the MAC to understand the value proposition of why this is important. So thank you for going through that for everyone.
Mm-hmm.
Sorry, somebody else was first. Go ahead. But Dina, did you want to go first?
I know that there has been a lot of research done through the Utah Department of Health about postpartum women. and their death rates. And they did a long-term study, and these women do need health coverage because we do have a higher rate of death among postpartum women. A lot of it can be related to suicide, related to postpartum depression. And if they don't have access to health care, then they can't get help.
Yes, thank you. And I'm not trying to question that premise. I was just trying to say there's already a certain type of coverage available to a person of that income level, and was asking the department to just clarify the advantages of having them be in this category of Medicaid eligibility as opposed to the adult expansion category of eligibility. Stephanie, you have a question?
Yeah, I'm curious, how the number, like, what is that's almost $3 million. So if it's a third of the pregnant women are really the ones that are being targeted because they would have otherwise lost coverage. I mean, how many women is that? And so, like, where is that? Is that just because of like does it have something to do with like their rate setting that the health plans are? That number just seems like a lot, but maybe that's because I misunderstand how many women are going to be affected. So I'm just curious if you can break down the math.
Sure, I'll do my best, and Brian, please fill me in if I miss anything here. So typically when we make a request like this, we look at what would it cost. We analyze the difference in cost between, okay, how many of these people would roll to the expansion program, as Michael mentioned, or how many of them would just simply lose coverage. So we take, based on historical data, we take our best guess at what we think that would look like in an ongoing basis, and then run the math, assuming a federal match rate. So this is just the state funds that would be applied here. There would also be federal funds that would come in and supplement this. And so the math is basically just looking at past performance and trying to make our best guess at what this would look like on an ongoing basis.
So,
And then how many women? Oh, sorry. Go ahead, Brian.
Yeah. So yes, correct. So what we see, there's a little bit of a challenge here, which I want to acknowledge, that we only had full expansion beginning January of 2020, and then the public health emergency began soon after that. So we haven't had a lot of good experience of what enrollment changes happen post full expansion, absent a public health emergency. But what we can see based on who's forced issuance in the public health emergency is that about 212 members per month would lose eligibility. So if each of those 212 members were to get 10 additional months, our per member per month is about $434. And that's how the math comes out. So 212 times 10 times 12 for a year, and then multiplied by 433. So, but if you want kind of a greater breakdown, we can certainly walk you through that.
Thanks, Brian. So the per member per month, is it the same? What is that compared to the adult expansion population?
We budgeted in essentially equivalent to the adult expansion, what our parents on adult expansion experience, which is, so that's how it comes from. Many of them postpartum women themselves, but not all of them.
Okay, gotcha. Okay, thank you.
Mm-hmm. Okay, and it looks like we've had a question come in from Representative Lesser.
Thank you. Actually, this is just a follow-on. Don't we have the data on cost per for postpartum care specifically, especially since we have that larger group that's been part of the public health emergency? And the question is do those individuals have they been acquiring and costing as much as a standard Medicaid expansion individual?
Yeah, it is a good question. Some of this would break down to, we have the data out there. Some of it would come down to how we set the rates. And what I believe what we would do is set the rates so that they get the pregnant woman rate right now, just for a longer period of time, which is a set capitated per member per month over the entire period of pregnancy and postpartum. But we would probably want to discuss with Milliman whether this would require a rebasing. Milliman is our contracted actuary. So it is a good point, and I think pre-session we should have some discussions about whether it would warrant a relook at the rates for pregnant women.
Great, thank you.
Mm-hmm.
All right, Eric, thank you. Let's go on. But I think we've got a flavor of the additional value of having pregnant women remain in the pregnancy category. Destiny mentioned in the chat that they also have a dental package that's available to them, which the adult expansion population does not have, that hasn't come up in the discussion as well. So several reasons why this makes sense, and just would like to have people understand if people are asking why this type of coverage versus just moving to the adult expansion. So let's continue. Thanks.
Great. Thanks, Michael. Okay, next up, we received in the governor's budget, we have $1 million ongoing for funding for the medically complex children's waiver. We anticipate this will be at least 130 additional members, but probably more. We're still crunching the numbers on that to try to figure out how many more this would include. Next, we have the community transitions waiver, $544,000 ongoing and a one-time reduction of $109,000. Basically to increase nursing rates for services provided to individuals moving out of intermediate care facilities and into the community. The one-time reduction is anticipating that it won't all happen immediately July 1st. It will take time to work through the system, so it's a one-time offset there. Finally, we have social detox rating improvement, $411,000 ongoing to increase social detox, or the rate for social detox services through the Office of Substance Use and Mental Health. The daily rate will be increased from $89 to $175. And that ends the presentation on items included in the governor's budget.
Oh, you're too modest. I have a few questions.
Well, it ended my presentation. Questions are always
fair enough. Yeah, so I haven't made it through all 188 pages of the document, but on page 29, it talks about, and this is larger than Medicaid, that the Department of Health and Human Services is picking up the Clinical Services Bureau from the Department of Corrections. Will Medicaid have any role in coordinating with that, or how do you see that initiative, or do you have any information on that?
I have no information on that, Michael.
Oh, you're not very helpful.
Look into it, and I will get back to you.
Okay.
I think as I understand it, the extent of our involvement would either be in a consultation basis or attending certain committee to implement it, but not a direct oversight in any fashion.
Okay. And then on page 31 of the governor's budget proposal, there's talk of a physical and behavioral care integration, committing that 5,000 additional Medicaid members will be in an integrated physical behavioral health setting by the end of June 30th, 2024. Do we anticipate that is the TAM integration into some type of a physical behavioral health, or is this something else envisioned in Medicaid? Or would you like to review it and get back to us in January?
I would absolutely love more time to review it and get back to you.
All right, so it's on page 31 of the governor's budget proposal.
Sure.
And then
notes, that's why I'm looking away. So
very good. I know you don't get consulted as this document is put together, so I'm just curious. And then the final one that impacts Medicaid, value-based payments, it says that in fiscal 24, that would start July 1st, DHHS will make $30 million of payments to ACOs contingent upon the organization's meeting established quality measures. So I'm not guessing that's new money, since that didn't appear in your presentation of building blocks. So what is envisioned on those value-based payments?
Again, working through that one, and happy to give you a better report back in the next MAC.
Okay, great. All right, does anybody else have any questions? I'm just the only question guy on the budget. Okay, well, but you love my questions, so I make up in quantity what we miss in breadth of interest, maybe.
Nope, they're great. They're always good, and we're happy to look through them. As you know, we get surprised too sometimes with the governor's budget.
Never happens.
We're totally in the know on everything.
I'm sure they clear everything with you before it gets released. Yes. All right. Thank you, Eric. That is great. We appreciate the report. And could we have you give that content to Sharon so she can distribute it to the MAC, since it wasn't part of the meeting materials, just so people have a chance to review that? That would be helpful.
You bet.
Okay. Given where we are on time, and the MAC bylaws will probably be able to wait until January before we make the changes, I'm going to just skip over that and move to item number 7 on the eligibility and enrollment update, and we'll have that be our last item on the agenda for today. So Jeff, do you want to jump in on that for us, please?
Absolutely. Let me see if I can share my screen. You've seen we've had some fun with that.
Yes, and you're growing a beard. It's looking very Santa Claus-ish.
Or not shaving as well as I should. Are you seeing anything?
Yep, we got it. Thanks.
Wonderful. All right. So this is not included in your packet, and I'll explain why. And yes, you will get it as soon as this meeting's over. We'll have Sharon forward this out to everybody. So first of all, it's good to be with you again. The quick update on the public health emergency, you have already heard from Eric, so I won't repeat too much of that, I hope. This is the current number of folks that are being held open. I want to focus on that number right now for November of 258,079 individuals being held open in the EREP system, in our eligibility system. You'll notice that there's missing some purple graphs here, hence why we didn't get this out. And you probably also noticed that you didn't get some information that you normally get in your regular MAC packet. We are working right now to recreate what's been formerly called the Kaiser. So hopefully you can still hear me. Connection issue on my end. I'm so sorry. But we are working on changing the Kaiser report to be an online report that you can see in a more nimble way. Hopefully we'll be able to post that online that you can see all the time. I've seen an early version of that, an early draft of it just today. It looks very exciting. You'll be able to see a lot more detail than you have in the past. And so we're working to validate that report and get it out to you as quickly as possible. But what that did mean is we couldn't pull those numbers and be consistent with what we have here yet. But next month, we intend to release both things, and you'll see an updated version of this chart as well. You heard from Eric, we did not get 60-day notice on the public health emergency, leading most of us to believe that we'll see an extension in January. There are several options that could change what happens in the world, and we'll be watching carefully to see what that means for us. Everyone can pick a date on this call, and with probably some of us might be right. We'll see what that means next year as we look forward to an unwinding date, I think next year. We have requested some flexibilities on the eligibility side to make things easier for the enrollment. We've listed those here, and again, you'll get the copy of the report. A couple things to call out, I think, that are helpful is that we'll be able to do some expedited renewals for this specifically helps individuals that don't have any income or there's no data return for them. It allows us during that period of time of the unwinding process to simply run with the data that we have and approve or reauthorize those cases without having to contact someone. This will particularly affect those perhaps that are homeless or they're not showing any income at this point in time, and allow that to be approved more easily. So we're excited to see that happen. And then two, that help us get returned mail information and more quickly update our addresses without having to go out and contact an individual to make sure that address change has actually occurred. That helps speed up that process so our contact stays up to date more quickly. And our last approval just came through in the last couple of weeks to allow us more time should the fair hearing request. So this is likely if someone's benefits have been terminated. This allows us to more time to make that fair hearing decision and to continue their benefits while that fair hearing decision is being discussed. So those are really good amendments, we hope, that will help ease us into that unwinding period. And the last pieces you've seen before, but I wanted to point out the very, very last bullet, which is that we're rewriting our ex parte review policy to ensure that an attempt is made on all cases. And that's something that we have not done well in the state of Utah. What this means will be that workforce services, as a case is picked up and looked at during this period of time, they will try to do everything they can on their own with the data available to us to renew that case and then move forward. So that's a very, very good change. It's one that will stick around post all of this. So we'll be doing more ex parte reviews, and that will become part of the regular terminology you'll hear from us. And we'll be able to track that as well and show you that data that you'll see again on that website once that is up and running. So that's a very quick synopsis. I know there's only 4 minutes. So what questions might you have?
What is the enrollment for the month of November, since we didn't get the report?
I don't have that number. Do you have that, Brian, perhaps?
I'm sorry, I do not have that.
Nobody has it. Well, then I don't feel quite as left out. We will wait for the update.
You can
All
see
right.
that the trend will keep it just probably 4,000 or 5,000 individuals higher than what you've seen. The trend has not changed.
Okay. Does anybody have any questions for Jeff from the members of the committee? Anyone from the general public? Okay, well, I think that's a good meeting. I appreciate all of the information that has been shared. A lot of information for people to take in. We will plan to have a MAC meeting in January. We usually have the ACO quality report in this meeting in December, so we've moved that to January. So we'll have that as part of our next meeting and address the MAC bylaws and a few other things that we've talked about in this meeting. And then if any of the members of the committee have items they would like to put on the agenda, if you want to contact me through Sharon or directly about some of the items you would like to have discussed in a future MAC meeting, please let us know and we'll try and work those into future agendas. Does anybody have anything they'd like to bring up before we close? A lot of holiday wishes being extended in the chat. Very good. Thank you. All right. If there's nothing left, then we'll go ahead and end our meeting today and look forward to seeing everyone in January. Hope everyone has happy holidays, and thank you again for all of your work at the department and for everybody's engagement in the program. Thank you.
Thanks, everybody.
Thank you.